our webinar series. Our webinar today will discuss Ependymoma, a discussion of treatment options and associated quality of life concerns. My name is Jillian Demas, Senior Program Manager here at the American Brain Tumor Association, and I'm delighted to introduce our speaker today, Dr. Buffet. Dr. Eric Buffet is a sponsor for an ABTA-supported International Outreach Fellowship for Dr. Krishnatri. He is a professor of pediatrics at the University of Toronto and head of the neuro-oncology section in the Division of Hematology Oncology at the Hospital for Sick Children in Toronto, Canada. He is also a senior associate scientist in the Research Institute at the Hospital for Sick Children. Thank you so much for joining us, Dr. Buffet. You may now begin your presentation.
Thank you very much. Good afternoon from Toronto, where there is still snow on the ground. So I give you a few seconds to adjust to my accent, which is still a sticky French accent from my roots. And today we are going to talk about ependymoma, and particularly the treatment and the issue of quality of life of children with ependymoma. Ependymoma is the third most common brain tumor in childhood, and this is a very complex disease. What I want to do today, and I know that from your background you may have a long experience in dealing with ependymoma because your child was diagnosed several years ago, or recent experience because your child was diagnosed yesterday. So I want just to go over most of the issues associated with ependymoma, and also I wish we have some time at the end to discuss some of the challenges and some of your questions. So that's the plan, the template of my presentation. First, the controversies, and I will go over the result of recent protocol, the management of recurrent ependymoma, which is a critical and new topic, and where we go next, the future direction. I will first start with an old publication which was 16 years ago when I was asked to do a review of the literature by the European people, and we identified a few problems. Pathology was a problem. The role of chemotherapy was not really established at that time, and radiation was an important factor for survival in ependymoma. And in fact, these three topics are still very, very up to date today. But the most important fact that we identified that it was clear that we needed clinical trial. So 15 or 16 years later, we have developed clinical trial, we have learned a lot, but we still have a lot to learn about, the biology in particular of this tumor. So what we have learned is there are significant players, and I will mention them by order. It's a bit of a cartoon and you may laugh, but certainly the most important player is first the neurosurgeon. And the neurosurgeon is critical, is key, is the best ally just to remove the tumor. And the second player, the second important player, is a radiation oncologist. And we'll see that in fact, it's regardless of the age of the child, despite the fact that we still are cautious when the child is less than 1 year old. So you may say, where is the oncologist here? And in fact, the role of the oncologist is unclear, and I put this slide as part, of the question mark. So what do we expect from neuro-oncology or oncology, and particularly in terms of chemotherapy? But let's go to the controversies. And the first controversy relates to the pathology of this tumor. And you see on this slide that there are different types of ependymoma according to the grade. Grade 1, which is not the topic of my talk today, but essentially grade 2 and grade 3. And with grade, we mean, so the higher the grade, the more aggressive the ependymoma. So it seems to be obvious and easy to understand on paper. And when we look at the grade 2 and grade 3, it makes sense that if you have a grade 3, it's more aggressive. If you have a grade 2, it's less aggressive. But really, does this matter? And in some series which have been reported, for example, the St. Jude series, yes, it matters. It seems that the classic, the grade 2, are associated with a much better outcome than the grade 3. And the issue is there are sometimes, and there have been many examples of studies which have challenged this sort of evidence. And I take one protocol which has been recently published where, as you see on this table, the pathologists at the institution identify in fact 3 types because they were not sure for some of the patients whether there were 2 or 3, so they put them in the middle. But you can see that the benign had a good outcome and the anaplastic, the grade 3, had a poor outcome. So it was certainly in agreement with what we were expecting. The problem is this protocol has conducted a central pathology review. And look at what happened at the end of the central pathology review. It was upside down. So the benign were doing worse than the anaplastic. Why? I don't know. But this has been identified as a problem by many people. And in fact, when we did our review of the literature in 1998, we were surprised to see that in institutional series, the percentage of patients with anaplastic ependymoma could vary from 7% to nearly 90%, showing that there was no consensus whatsoever. So what can be called as a grade 2 in one institution will be a grade 3 in another. And in fact, this issue has been even more identified or confirmed when Dr. Ellison and Dr. Grundy decided to have a consensus meeting inviting pathologists to review slides of ependymoma patients and to find an agreement. And in this experience, they concluded that there was, despite the fact that there was an agreement on the definition between the different observers, there was a significant disagreement at the end of the day. So once again, pathology is a big issue, and whether it's a grade 2 or grade 3 is still unclear whether it makes a difference, in particular when we see the difference between institutions. Now, the second thing is, so what about surgery? I told you that surgery is critical to, for the treatment of ependymoma. And the question is, if the surgeon is unable to remove all the tumor, can the tumor be removed in a better way by another surgeon, or what are the factors that may influence the completeness of resection of the tumor? And in fact, this is interesting because on this slide you can see that this illustrates the number of, the percentage of complete resection in some protocols that have been reported. And I want to show you this. So that's a number of European studies in infants and in older children which suggests that between 30 and 50% of the children do not have a complete resection. And then came the experience from the St. Jude group. And this group reported an amazing 90% completeness of resection in their series. And some people say yes, it's because it's biased, because they have a selection bias, because they are too aggressive, because all the kids have tracheostomy and nasogastric tube. But in fact, when they presented the data was so convincing in terms of benefit, showing the benefit of the resection, that the subsequent North American study from the COJ, which is called ACNS 0121, achieved not exactly the same rate of complete resection, but an amazing 80 to 85% rate of complete resection, showing that if you really show convincing data to the surgeon, they may change their mind. So again, so this has illustrated the fact that you can influence the rate of resection by working together with the surgeon and by advocating for a better resection rate. So now the question is, does this affect quality of life? And this is important, this is critical in terms of your child and his life. And in fact, the quality of life related to surgery is poorly documented. There is some evidence that more aggressive surgery is associated with a higher risk of morbidity. And in particular for the children who have tumor in the posterior fossa, which is in the back of the brain, there is a risk of this complication called mutism, and mutism is a lack of speech which comes after the surgery, and usually the child will talk for half a day or 1 day after surgery, and then we stop talking, and then the period of mutism can last for several days, several weeks, sometimes several months. And when the speech comes back, it doesn't come back the same way as it was before. So that's one of the complications that we identify after this type of surgery. And the other problem associated with the surgery of ependymoma, which relates to the infiltration of the tumor around the brainstem and the fact that they encase some of the cranial nerve, are the risk of complication related to the damage of these nerves, and in particular swallowing issues. And a number of children, for example, in the series from St. Jude had required a tracheostomy and G-tube because they had impairment of their swallowing for a number of months. And the question is, does this recover? And in fact, there was a very interesting report 4 years ago by the team from St. Jude, and they looked at this and they say, yes, there is some recovery over time of this function, and most of the kids who had the tracheostomy or who had nasogastric feeding eventually could be taken off the tracheostomy tube. There are some risk factors for a slower or more delayed recovery, and these factors are just here down the slide. Male, where the risk in boys is nearly 3 times higher than in girls. Age, younger age, is associated with a longer delay for the recovery. The tumor volume, the bigger the volume, the higher the risk of morbidity associated with surgery. The number of resections, a child who requires 2 or more resections has a higher risk. And the fact that the child has required what we call CSF diversion, so a shunt for the treatment of his hydrocephalus. So now the surgery has been done, and the question is, what comes after surgery? And the question is really, is there a role for observation? Should we give radiation, or should we give chemotherapy? And in fact, for every single oncologist and neuro-oncologist who has some experience of ependymoma, the only answer is the postoperative management relates on focal radiation. And focal radiation means you have to target the tumor volume with conformal radiation, ideally, so which can shape the tumor. So it's called 3D radiation or IMRT, and it should irradiate the post-operative tumor bed and not the pre-operative tumor bed, so what's left with the tumor and the tumor bed around, with a margin which has decreased over time, and the margin has reduced now in the most modern or current protocol to 0.5 centimeter, because ependymoma, it's not a tumor which really infiltrates the surrounding brain. It's a tumor with very clear margin, so we don't need to have very large margin when we give radiation to the tumor bed. And the dose should be 54 to 59, this is what is called conventional dose of radiation, in 30 to 33 daily fraction, that's 6 weeks to 6 weeks and a half. So, and there was a time, and so this is important because still some old school consider that craniospinal radiation, which is radiation to the brain and the spine, should be considered particularly for patients with anaplastic or grade 3 ependymoma. This is related to a very old study published by somebody called Salazar, and who has reported that when he was doing autopsy on children who died from ependymoma, he could see dissemination or spread of the tumor to the brain and the spine. And then he embarked a generation of physicians into an elective approach with craniospinal radiation. But today, this evidence is lacking, and again, the standard treatment is based on focal radiation. So over time, in fact, we have moved from the treatment of the most common ependymoma, which is the posterior fossa ependymoma. We have moved from a large field of radiation to the whole posterior part of the brain to now a very small field of radiation that encompasses only the tumor volume or the postoperative tumor volume. And so this is important to shape the volume of radiation to the tumor bed and only the tumor bed, because they are very important organ around. And I can mention the hearing apparatus, the cochlea, the ear, the temporal lobe, which relates to the memory and a number of very important intellectual function. Anteriorly, the hypothalamus and the pituitary gland, which control all the hormone, and down the spinal cord. So if you can spare the radiation to the surrounding tissue, it's going to minimize the morbidity of the treatment. And of course, what does this mean? That the tighter the margin of radiation, the better the treatment. And in this context, at least on paper, ependymoma is an ideal candidate for proton treatment. And there have been a number of papers which have looked at this and have shown that when you look at the exposure of the surrounding tissue to the radiation treatment, for example, when you look at what it does to the upper brain, when you use conventional radiation, you will give significant amount of scattered radiation to the surrounding brain. When you use proton, the amount of radiation is much less, so you spare the surrounding tissue. And the same for the cochlea, for example. So it means that, at least on paper, the use of proton is considered as certainly the best option for the treatment of ependymoma. And in fact, it's clear that there have been some experience, and particularly the experience that has been reported by the team from Boston, and they have shown that the result in terms of tumor control was similar to the result that we were reporting in terms of treatment with classical photon treatment. And in fact, when you look at the use of proton in North America and the United States, it's striking that even if this tumor is less common than medulloblastoma, that's a paper from Dr. Merchant, a review of the use of proton in the States. You can see that a large number, and which is pretty similar to the number of children treated for medulloblastoma in North America, were treated in 2012 with proton, and we can estimate that nearly 1 in 2, 1 in 2.5 children in North America has been treated with proton for ependymoma, even if it was not in the context of a clinical trial. Now, what about chemotherapy? And I picked from the literature a few sentences on chemotherapy. So chemotherapy, there have been a number of trials that have identified some activity of chemotherapy. And so far, from this trial, we can say that cisplatin seems to be on paper the drug with the best activity. Etoposide of VP16 has some activity. But when you put together the result of the studies that have used chemotherapy, there is no clear evidence that chemotherapy improves the event-free survival or the overall survival. It means the outcome of children with ependymoma. There is also some evidence that when you combine chemotherapy together, the response rate is better. So there is some activity of chemotherapy, but whether this activity affects or improves survival is still not demonstrated. And in fact, when you look at the activity or the result of chemotherapy, the response rate to single agent, that's a paper I published a few years ago, is very modest. in the range of 10 to 15%, and the number of children who had a complete response with chemotherapy is even lower, less than 5%. When we look at the new agent, and I put a list of the new agents that I identify from a literature review, you know, this drug called a targeted treatment, there is no clear evidence that any of this treatment has an activity which is worth it to some extent. And when you look at combination, there is a modest improvement in response rate from 12 to 17%, but the completeness of resection is still very disappointing. So again, on paper, no obvious evidence that chemotherapy is a must in the treatment of ependymoma. So why do we talk about chemotherapy in ependymoma? In fact, the reason why we mention chemotherapy comes from a work that was initiated by Dr. Foreman, who is now in Denver and started this work when he was in the UK in Bristol, and reported a potential benefit of chemotherapy in facilitating a second resection after an incomplete initial resection. And in fact, this was the first time chemotherapy showed really a potential role in ependymoma. And there were two studies, the SIOP study and the COG study, which have evaluated the role of chemotherapy in facilitating the second resection after a first incomplete resection. We are still waiting for these two studies to be published, but we are just we have adopted this approach and consider that a child with an incomplete resection is a potential candidate for chemotherapy in order to facilitate a second resection. So this is, for example, the protocol from the SIOP group that I initiated before it was conducted by Dr. Grundy. And so the children who had no residual tumor were treated with straight radiation, whereas the children who had residual tumor in complete resection were treated with courses of chemotherapy, either 2 or 4, depending on the result of the scan after 2 courses of chemotherapy, and then they had surgery when it was possible, and then they were treated with radiation. So really the role was to make everything possible to complete the resection prior to moving to radiotherapy. That's an example, courtesy of Dr. Grundy, who gave me this slide. So of a patient who had a biopsy, and you can see the tract of the biopsy here, and then proceeded to chemotherapy. You can see that there is a modest shrinkage, but the tumor is still huge. But after the shrinkage, the surgeon was more confident, the team had a great discussion, and look at this beautiful resection after this trial of chemotherapy. So this is ideal, but this is the way chemotherapy has been promoted in the treatment of ependymoma. So currently, so in this context, there was also a study by the Children's Oncology Group. It looks a bit busy, but it's pretty much the same as the European group. So children who had a complete or near complete resection were treated with conformal radiation. When the resection was not complete, there was a residue on the scan. They were treated with chemotherapy, then evaluated, and if they could have second look surgery, they proceeded to second look surgery and then radiation. If they were not able, or the surgeon was not able to consider surgery, the child was treated with conformal radiation. There was a third arm, and I will be very quick with that. That was for children who had a differentiated grade 2 supratentorial ependymoma. Supratentorial means above the posterior fossa, the back of the brain, and these children were candidates for observation. This relates to a very, very limited number of cases. In fact, 10 out of 350 in this trial. And this trial was completed in 2007, and we have now some follow-up, and I will show you some of the results of this trial, which show that the overall survival of the patient is quite good compared to historical data in the range of 80 to 85%. The event-free survival, which is the survival without recurrence or progression of the tumor is not as good. You can see that it's around 50%, so which means that the tumor can still recur even if you have a complete resection. And in fact, this trial showed that the kids who are doing the best were the kids from stratum 1, 3, and 4, who were the children with complete resection or near complete resection, whereas the children who had an incomplete resection had a much poorer outcome in the range of 35% event-free survival, which means survival without any progression at 5 years here. So which means that if a child has residual tumor and proceed to radiation, if there is residual tumor at the end of treatment, so this is the survival curve which illustrates the risk of the child. So this is why we are so eager to achieve a complete resection in the context of ependymoma. In this trial, there was also some evidence that the children who had differentiated of grade 2 ependymoma were doing better, but the difference is not very large and still question the role of the pathology in the context of this of the decision-making process, which is not the case. Most of the team, at least in North America, consider that we should treat the same way differentiated and non-differentiated ependymoma. Now the big question is, can chemotherapy improve outcome after an incomplete resection? I showed you that, when you have an incomplete resection, the prognosis of these patients is certainly guarded and much lower than the children who had a complete resection. In fact, there was a trial called 941 that was conducted with two options. One was the patients who had no evidence of residual tumor were treated with straightforward radiation, and the patient with residual tumor were treated with chemotherapy prior to radiation. And in fact, it's striking that the outcome of this trial shows that the two populations of patients had exactly the same outcome. And the result of this trial were taken as a message that we might be able to improve the outcome of kids with incompletely resected ependymoma by giving some chemotherapy. It's not demonstrated, and this is why the Children's Oncology Group has decided to put this into a randomized question, which is today we are trying to figure out whether the result of this trial are really in favor or confirming or suggesting that chemotherapy may add a benefit. So the only way to answer this question is to have two arms. One is a group of patients who have chemotherapy and the other group which has no chemotherapy. But in order to really answer this question, the member of the Children's Oncology Group have decided to explore this question in the context of what we call the good group of patients. The one who have a complete resection, then proceed to radiation, and then are randomized between maintenance chemotherapy or observation. Very difficult question, and many parents struggle with this question because it means that 4 months of chemotherapy versus no chemotherapy, and the physician in charge are not the one who decide. This is done by a computer. But this study is asking an important question. This protocol is going on, has already accrued more than 100 patients, and we hope that within 3 to 4 years we'll be able to answer this important question as whether chemotherapy adds to the benefit of radiation in the context of completely resected ependymoma. In this protocol, the children who have an incomplete resection proceed all to maintenance chemotherapy. Why? It's because the outcome of these children is not satisfactory. You saw that it's 35% event-free survival, which is really not good. The SIRE protocol, which is the European counterpart of this North American COG study is having the same type of design. So really the question is chemotherapy or no chemotherapy for you who are the parents of the children with ependymoma. And there is really no evidence that adjuvant chemotherapy improves survival from the data we have. And in fact, outside clinical trial, I would say, me as a physician, there is no role for adjuvant chemotherapy unless a child is part of these two important COG or SIOP clinical trials. Next question is, and what about infant? There was a time where, until 2004, 2005, where children less than 3 years old, no radiation. This was considered unethical, and the results of this protocol were reported where children were treated with surgery followed by chemotherapy. And so we were comparing the chemotherapy regimen and saying this regimen may be a bit better than this one, but really the outcome of this protocol were not satisfactory. And even if some people used to say, oh, but we can give a second chance to the children, if the tumor progresses, then we consider reoperation, and then we give radiation. So this is the example of the French protocol, which was published in 2002 or 2003, and which shows that the survival of children, infants treated that way is not really very good, with an event-free, an overall survival at 6 years in the range of 40%. And then came the experience from St. Jude, in which Dr. Merchant and his colleague decided to consider that this cutoff of 3 years old was really based on really no clear evidence that it was detrimental to give radiation under this age. And he decided to give radiation to children from the age of 1 and reported the first result in 2004 showing an amazing event-free survival of 70% for these children treated with focal radiation. You may say, yes, but what about their functioning brain? What about the damage to the brain that is caused by this approach? And Dr. Merchant reported the intellectual outcome of these children and said, yes, there is some difference in the intellectual outcome when we look at another group of patients, but this difference is already present at the time of diagnosis, suggesting that the difference is caused by the tumor and not caused by the radiation treatment. So again, there is now increasing evidence, and we have learned from this experience that young children can be treated successfully with radiation, and the outcome can be excellent, including their academic outcome, because the radiation is very, very conformal, very with small margin, and really has minimal impact on the functioning brain, even if the tumor is located in the upper brain called the supratemporal region. So I mentioned that I will discuss the treatment of recurrent ependymoma. In fact, I put this slide just to show that there was 25 years ago nearly a publication that really suggested that the outcome of recurrent ependymoma was poor, and that the main factor to influence this outcome was the fact that the surgery could be done at that time, but the tumor was benign or grade 2, and but it was a first relapse. But still, when you look at the survival curve, it was very worrisome. So pretty much the recurrence of an ependymoma was pretty much a death sentence. And then came a message again from the same team from St. Jude, and they reported in 2008 the result of a study using ray radiation for recurrent ependymoma. First time ever, people were using twice the same treatment to treat the tumor. And in this experience, they reported an amazing survival and sometimes long-term survival up to 10 years of these kids who were treated with a second shot of radiation. Whether it was radiosurgery, focal radiation or craniospinal radiation. So the technique is still a matter of discussion. And in fact, there were also other techniques which were reported, but more experimental, by the Chicago team using intraoperative radiotherapy with a device where the radiation is given at the contact of the tumor, but the data on this technique are still limited. But what I want to say, we have used this technique in Toronto over the last 7 years or 8 years, and clearly our experience shows that first, when we treat with ray radiation at 3 years, we have made a dramatic difference in the survival of these children, from around 10% or less than 10% to nearly 80% at 3 years. There is no plateau, which means that some kids keep recurring after over time, but the improvement in survival has been phenomenal. And what we have seen also is that compared to what we used to see in the past, the first recurrence was followed by a second recurrence more rapidly. When you use ray radiation, in fact, you see that the second recurrence comes, in fact, later. So you have some extra time, which can be even much longer than the time between the first diagnosis and the first recurrence. So this is, of course, a very sophisticated technique that can be applied only in some selected center, but people have now shared the information, and the technique has expanded in a number of different institutions. So this is certainly something which has changed the outcome of many children with recurrent ependymoma. There is a cost to that, and we have measured this in Toronto with a decrease in the IQ related to the ray radiation, which is often a decrease between 5 and 10 points. But you know, this is the only way we can really save the life of the children we treat. That's an example of a child treated first for this large ependymoma. There was some residual tumor. The child was treated. He still had residual tumor on the follow-up. And then he had a recurrence here, for which he underwent surgery and ray radiation. And for a cumulative dose of radiation, which was unbelievable at that time, and that's his scan 3 years after the ray radiation treatment. So there are still questions for the management of recurrent ependymoma. What is the minimal interval since the first radiation? We don't know. Some people say 4 months at least. Whether the radiation should be focal or craniospinal. And in that context, I would say in Toronto, we have adopted more and more the use of craniospinal radiation, because we see that many children who relapse a second time relapse with distant spread of the disease. And is there any role for chemotherapy before or after? And at this stage, there is no evidence that chemotherapy adds to the outcome of these children. But when we give early radiation, we can see this type of reaction that I show on this scan. So that's the scan 4 months after, 3 months after the radiation, which was suggesting of a recurrence of the tumor. In fact, it was called radiation necrosis, and which over time improved. So this is a type of reaction that we can see. So what have we gained from this different approach? Giving radiation to younger children, giving ray radiation to to patients who have failed treatment. In fact, I show you this slide, which is the survival of children at Sickkids between 1990 and 2013. And the overall survival is not great, in the range of 40%. But when we divide by a period, you can see that the overall survival in the most recent period since 2004, when we changed and we started to irradiate young children, we started to use ray radiation, has dramatically changed with a much higher survival today compared to the past. Now, what's coming next is very important, which is the biology that comes into the equation. And scientists have identified a number of pathways, and with the pathway, a number of possibilities to treat ependymoma with some new targeted agents. And there are a number of agents which have been tested or which will be tested in the near future, but I list here. Lapatinib has been used in the context of a clinical trial, RAD01 as well. But so far, these agents have not really confirmed the fact that, or the expectation that we had, that they would change the fate of ependymoma. And in fact, there are a number of clinical trials either which are going on or which have been conducted in North America that relates to ependymoma, and we hope that these clinical trials are going to make a difference. What I want to do, just to wrap up, is just to show what's coming next. Certainly one of the important work that has been done has been conducted in Dr. Gilbertson's laboratory in Memphis, where he identified the genomic of ependymoma and identified, in fact, 9 different families of ependymoma. So it makes the story even more complex because you say it's not only 1, it's 9. But what can be done from that? And what Dr. Gilbertson has done with his team is to develop mouse models for each type of ependymoma and to test drugs. And for example, for the group D, he has been able to develop a mouse model and then to select amongst a number of compounds, a winner, so the one with the best activity, and he had 2 winners. But the reason why he selected 5-FU, the fluorouracil, was because this drug, bortezomib, didn't really cross the brain barrier. So, and this is why there is currently a trial of 5-fluorouracil or 5-FU going on in Memphis, and which is going to expand soon in a larger collaborative study. The other work I want to mention is a work by Michael Taylor and the group in Toronto, and they have focused on the ependymoma in the posterior fossa at the back of the brain and identified 2 groups, and they have worked together with the group of Stefan Pfister in Heidelberg, and really they have flagged up the fact that there is a group A and a group B ependymoma, characterized by not really by a difference in the number of genes mutated. In fact, in ependymoma, there are very few genes which are mutated. And that's a difficulty to find a target, because if you don't have any mutation of gene, you are unable to find a target. But they did a step-by-step approach. First, by identifying this group A and group B, and say group A, they are younger kids, they have a higher recurrence rate, and their survival is much lower. Then they said, in fact, when we look at the mutation in this group A, it seems that this is really a group that has very few mutations compared to the group B ependymoma. So if there is no mutation, there must be something else. And they decided to look at what we call the epigenetic changes, which are on the envelope of the gene. And so what I will come back to that, but what they also identify when they looked at this ependymoma, the group A, and that's a very important message, is that when they are not completely resected, this group A ependymoma, whether you give radiation or no radiation doesn't make any difference. So which means that it's only the completeness of resection that will have a significant impact on survival when you give radiation. These tumors are very aggressive. If you leave some tumor behind, it's not good. Whereas when you look at the other ependymoma, which occur in older children, the role of radiation became less clear, because even if no radiation can be associated with a risk of recurrence, you can still salvage these patients when they recur by giving a second surgery and proceeding to radiation. What I want to say is also, and this is a message of hope, is Dr. Taylor looking at the potential drugs that could target this nasty, aggressive group A, or called PFA ependymoma, has identified a number of agents called demethylating agent that show some amazing activity on this drug. And so you have to trust me when I show you this. So that's cell lines or short-term culture of supratentorial ependymoma exposed to this drug and posterior fossa A ependymoma, and it shows a massive difference. This is a big difference in the survival, which a much lower survival of these drugs when they are, of these cell lines when they are exposed to these drugs. So these drugs are already on the market, and they are called decitabine or azacitidine. So two drugs which are already produced, and this is where there is a lot of hope currently in the context of ependymoma, because we want to put in place clinical trial that will first be offered to children who have failed treatment with surgery and radiation, but eventually there is confirmation of activity of these drugs. We will be able perhaps to integrate this treatment into the first-line management of ependymoma. And there are new drugs coming which seem to be more specific target of this PFA ependymoma called EZH2 inhibitors. And these drugs show even more significant activity when they are compared to an agent without any activity, which is a sort of placebo. So the 343, which is the EZH2 inhibitor, has leads to a massive cell death when they are put into culture with this PFA ependymoma. So this is my conclusion. When we look at the story of ependymoma, we have learned step by step. Yesterday we have learned that surgery was the mainstay of treatment. Today we agree all that surgery followed by focal radiation is the best treatment option. But tomorrow we certainly want, and we are planning to integrate the biology and to develop a new era of clinical trial. So I will not finish without mentioning the significant role of the CERN Foundation in the progress seen in ependymoma. The CERN Foundation is a foundation that has been developed at, in Houston, and this is an effort which is led by Dr. Mark Gilbert, who is a neuro-oncologist there. And thanks to the CERN, we have been able to develop a number of clinical trials, and I'm sure a lot more of the clinical trial with this promising drug are going to come from the CERN Foundation. So I finish here my talk, and I would be happy to answer any question you would have. Thank you very much.
Thank you, Dr. Fay. That was amazing. It was a wonderful presentation. We do have time for questions. So if anyone does have a question, if you would type it into the, if you would type it into the search box using the question box on the webinar control panel on the right-hand side of your screen, I will read your question to Dr. Fay. We have a couple of questions that were already submitted, so I will start with some of those. Someone is wondering about their child's eyes have been affected and the hand and foot have become weak. Is there any medical solution for this?
So the eye is always a problem because when the eye is a squint, we wait always a few months before, after the end of treatment, to discuss opportunity for surgery with the ophthalmologist. But we like to have some time because there is often some spontaneous improvement. As I mentioned, the ependymoma of the back of the brain, or called the posterior fossa, are often encasing a number of cranial nerves, and in particular the cranial nerve 3 and 6, which command the nerve of the eyes. And this explains why sometimes as part of the surgery this nerve can be affected. Again, when they are affected, it can be temporary, but it can also be permanent, and we need eventually some corrective surgery. for the feet and the arm, so it depends. It can be some weakness, and often the weakness, it depends where the tumor is first, but we often see over time some improvement of the weakness. What is much more challenging to improve is the coordination problem, because coordination relates to the function of the cerebellum, and this is a function which is very, very difficult to re-educate.
Thank you. Someone else was asking about that too, the balance in the ataxia. Sounds like a problem that's pretty prevalent.
So we have in Toronto, we have some exercise study, and so this will come soon as part of our publication from Toronto, which suggests that if you submit a child to intensive exercise, and we had exercise study with 150 minutes per week per child, and they were doing it together, so just to have fun, that we can have significant improvement in the coordination and the balance. So I think that this field is going to change, because we have been relatively passive and pessimistic so far, and I personally think that there is a role for active and intensive rehabilitation for this.
I like that forward thinking, and something that the patients can do, you know, for themselves with family involvement. So that'll be wonderful to kind of read that when it's available. Next question is, someone is wondering about re-irradiation. How much damage does it do to the brain?
So I mentioned quickly how we measure the damage. So we have evaluated the intellectual performance of the children who were treated with radiation, and we have noticed in our experience that the average loss of IQ was in the range of 10 points, which means that you know, in terms of learning, it can affect the learning. Of course, it depends on a number of factors, in particular the age of the patient and the technique of radiation you use. But when I see the patients who have been treated with radiation in my clinic, I would say I do not really notice a significant, major change in the way they function, in their school performance. And I would have no hesitation if somebody asked me whether re-irradiation is something that should be considered for a child with a recurrent ependymoma. You have seen my slides, so the difference in terms of long-term outcome is so significant that I would say this is a must, or nearly a must, if you can do it. I know that there are still some physicians who are reluctant because they say we don't have enough data, we don't have enough follow-up. But, you know, I hear and I see parents who say, even if the child eventually has lost the battle, they say, thank you, we have got 2 or 3 or 4 extra years because of this radiation treatment, and this was great.
Nice sentiment. With a recurrence within 10 months, is it safe to operate or re-irradiate within the 10-month period?
Both. So the slide that I have shown of the child who had some radiation necrosis, the interval between the first and the second radiation was only 4 months. And this is the minimum, so people are a bit worried when it's shorter than this interval. This child had a very incomplete first resection, was transferred under our care after he had progression of the residual tumor. But I would say also in the Memphis, the St. Jude experience, Dr. Merchant flagged up that children who had an interval less than 4 months were certainly at very high risk of radiation necrosis. So I would say 10 months is a safe period. Some people say they prefer 1 year, but there is no clear evidence that between 6 months and 1 year, there is an increased risk of radiation necrosis related to the re-irradiation treatment.
Thank you. Another listener is wondering if proton therapy is more applicable in slow-growing tumors, or is it applicable across the board?
No, I think so. I'm a bit biased here because we don't have the proton in Toronto, so we have very little choice but to send the children in the States, and we are always just a bit frustrated when we see this. But once again, it's very difficult to say that an ependymoma is slow growing or fast growing because the diagnosis of ependymoma comes like a slap in the face. You don't know when it started. So the only fact you can rely on is the grading, and as I said, the grading of ependymoma is so difficult that you can have a grade 2 in one place and you take the slide, you go in another place, it's grade 3. So I would say the answer is no. There is no clear evidence that proton is better for one type of ependymoma and not for another type. What I want to mention is that, however, we have limited experience of the radiation and re-irradiation with proton. This is still lacking, and most of the re-irradiation experience comes from the photon experience. So it's still something which needs to be looked at, whether a child treated with proton on the first occasion can be re-irradiated with proton, or vice versa. We have no idea.
Great. And looks like we have time for one or two more questions. Someone's asking about cannabis oil help children with ependymomas.
So, of course, in Toronto, we have also a large demand on cannabis oil. There are some data which are essentially from the lab, which suggests that cannabis has a role in inhibiting, so in decreasing the progression or the growth of some cell lines. Now, this role is so far very limited, and it's only in the batch. There has been so far no clinical trial. There have been a few clinical trials in adults with adult-type tumor, which have been non-conclusive so far. I know that there is a big push and a big belief from many parents, but we don't have any scientific evidence that cannabis oil has an impact on ependymoma or any other brain tumor in children. I would say, unfortunately, it's because we still lack experience, but it's also because these products have been put on the market so quickly and without any sort of scientific approach, that we are just caught by surprise as clinicians. And many parents ask the question. I would say, we as clinicians, the only answer we can provide is there is no scientific evidence. Doesn't mean that we are in support or against, is we don't know.
Thank you. That's an honest answer. And last question, so with this child with a second recurrence within the year, what would that family best do? Should they go for surgery, go for radiation? Which direction would you point them in?
So there are a number of questions with that. So some of the recurrence are focal, so in the same spot. Some are disseminated, so which means the tumor has spread. In Toronto, we review the situation, and we even encourage surgeons to go after every single bit of tumor, even when the tumor has disseminated, because still surgery has a very important role at the time of relapse. So surgery is still critical in this context, but if surgery is done, it should be a contract between the surgeon and the radiation oncologist, because as I showed you from the old experience from Philadelphia, published in the 1990s, surgery only, and this is our experience in Toronto, surgery only means that 2 or 3 years after the surgery, the chance, the odds to be alive will be in the range of 10%. So it should be surgery plus something, and at this stage the best option that we can offer to a child with a recurrent ependymoma is surgery plus radiation.
Thank you for answering all those questions. And that's all the time we have for today. Thank you for joining us, and thanks again, Dr. Maffei. For more information on ependymoma, visit our website at www.abta.org and view types of tumor under brain tumor information. Our licensed healthcare professionals can help you navigate our site. Just give us a call at 800-886-2282. So let's just pause for a moment and we can conclude our webinar recording.